Okay, good evening, everyone. My name is Anne-Marie. I'm one of the registrars here up in Manchester, and I've got the task to squeeze lung cancer in about a 45-minute session. I hope it'll take us slightly less. I won't cover everything because, as you all know, it's a massive topic, and the things I've left out are mostly concerning medical management, because I felt that was kind of taking the frame of this talk a little bit too far. So we're just going to jump right into the topic. There will be maybe a little bit of interaction. If you feel free to unmute, that's great. Or if you just want to type something in the chat box, that's also super. And then it won't be quite as boring. Right, so starting off with our learning objectives, I was asked to help you to learn a little bit or revise a little bit the anatomy of the bronchial tree, the lungs and the segments, the blood supply, talk about the types of lung cancer, the clinical presentation of lung cancer, investigations and the surgical management. And so we're starting off with a little bit of anatomy. So I'm hoping I'm not boring you all out of this, but as you might know, the lung has 5 lobes, 3 on the right and 2 on the left. So on the right side, we have the right upper lobe, the middle lobe, the right lower lobe. And these are divided by the fissures. So you have the oblique fissure running from the sort of outer superior part to the more medial inferior part, and then the horizontal fissure across between the upper and the middle lobe. And on the left, we have no middle lobe, because that part is, well, it's called the lingula because it's kind of attached to the upper lobe. And so we have a quite large left upper lobe and a left lower lobe. And you can see from the hilar side, the structure of the hilum, which is encased in a fold of pleura, but equally you can appreciate the horizontal and the oblique fissure on the right and the oblique fissure here on the left. So these are the basic divisions of the lungs. And then, of course, our lungs need to supply, well, they need some air supply in order to do their job of ventilation and oxygenation. So we have a system of air conductive spaces, which is the tracheobronchial tree. And you can see here the trachea in the center, down to the primary carina, and there it divides into the right main bronchus and the left main bronchus. And then from there, we get the lobar bronchi. So from the right main bronchus, we have a right upper lobe bronchus. And then so this is called the secondary carina, where that divides off the right main bronchus. And then the bronchus intermedium, which again divides in the middle lobe bronchus and the lower lobe bronchus. And the lobar bronchi then divide into the segmental bronchi. And we'll touch on the segments in the next slide. The left main bronchus has just a single secondary carina between upper and lower lobe, because, as I said, there's obviously no middle lobe on the left, but it's kind of attached to the upper lobe and called lingula. When you go into the left upper lobe bronchus, you see a bifurcation. In the right upper lobe bronchus, you see a trifurcation. So you see a bifurcation, and there will be a bronchus to the left upper lobe trisegment, which is essentially anatomically the equivalent of the right upper lobe. So it's the left upper lobe trisegment. And then there is a bronchus to the lingular bronchus, that then divides into the 2 segments of the lingula. And that can be quite helpful on bronchoscopy. If you sometimes, if the tube is not in the right place, or the anaesthetist is not quite sure where it is, and you look inside and you see the first bronchial uptake has a trifurcation, you can be most of the time quite sure that this is not the left side. Right, so much to a little bit of airway anatomy. And now then further on, all these lobes are divided into segments, and I will not bore you with reading out all of them. It's just to say that this is quite important for us nowadays, because some lung cancers can be treated with the resection of individual segments, and knowing how they all relate sort of spatially and how the airway anatomy is splitting up into these individual segments has become more and more important nowadays. I guess just to say, the right upper lobe has 3 segments, and in a way that the names are quite similar. So in the right upper lobe, you've got an apical, a posterior and anterior segment, and that's pretty similar on the left, albeit sometimes in some anatomy books, you'll find, like here, they describe an apical posterior fused segments on the left. And as you know, the left lung has slightly less volume because the heart effectively takes away a segment. But where that segment is lost, seems to really vary from anatomy book to anatomy book. Here they have basically described this fused apical posterior segment, and then in the lower lobe and sort of anteromedial segment, basically that will give you this loss of the one segment. Whereas other books will give you an apical and posterior segment separately in the left upper lobe and just describe the fusion in the lower lobe. So there is a little bit of variability, so don't be confused if you see it slightly differently highlighted than you do see it here. And then moving on to blood supply of the lung. So the lung receives some major vessels. So it's very intimately connected, of course, to the cardiac circulation. So the big vessel that pumps the blood into the lung, of course, is the pulmonary artery. And you've got a main pulmonary artery, a right and a left pulmonary artery. And they then give branches off into the parenchyma of the lung. And so for the upper lobe, usually on the right, for example, there will be several vessels. There'll be a truncus, there might be a second branch, and there might be a recurrent branch that kind of comes back from across the fissure. There will be a middle lobe branch, which is kind of outlined here, and then there will be a truncus to the lower lobe, and then often there will be a separate branch to the apical segment of the lower lobe. So these are quite important for us to know because they're often our landmarks when we end up resecting parts of the lung. And on the left side, very similar. So there's a left pulmonary artery. There will be several branches, usually to the left upper lobe, and there'll be a truncus and a segment 6 branch in the lower lobe, and there will usually be in the upper lobe part a quite distinct lingular branch as well. And then for the venous drainage, as you all know, there are pulmonary veins. They drain to the left atrium, and again, you will usually see quite a large superior pulmonary vein, inferior pulmonary vein each side. On the right, that divides quite early in an upper and middle lobe sort of tributary, and then a separate inferior pulmonary vein just for the lower lobe. On the left, of course, you'll just have a superior for the upper lobe, inferior for the lower lobe in terms of drainage. Now, very importantly, this is not the only blood supply the lung receives. The lung also receives blood from the systemic circulation, and they're called bronchial arteries. And interestingly, the bronchial arteries is along which the lymphatic drainage also occurs. So often lymph nodes, mediastinal lymph nodes, when we clear those, they will often be supplied from branches of the systemic circulation, and effectively can cause sort of annoying bleeds when they're not properly clipped or ligated. There are various descriptions of the anatomy, but usually you have got a couple on the left and sort of one that sort of splits up on the right. There are direct branches from the thoracic aorta. So you can imagine, again, if you're cutting around the bronchus, or you have to do an open procedure on the airways, if you get one of those incidentally, then there can be quite a bit of bleeding. And just again to re-emphasize this, so as you know, the pulmonary artery, that all is basically from the right-sided system, that is all low pressure. So, not sure what's happening here. I'll try drawing something. That is all low pressure system. So if, say, you cause a bleeding from the lung, or someone has an accident and a rib pokes into the lung and bleeds a bit, that is usually quite easily stopped with a bit of pressure, because as you can see, the pressure even in the right ventricle at a maximum is 25 millimeters mercury, because as compared to, as you know, our systemic circulation has a systolic pressure of 120. And by the time it reaches the lung capillaries, your wedge pressure here should only be about, should be very little. Jumped a little bit. Right, lung cancer in the UK is still fairly common, the second most common cancer for both men and women, and worldwide it is even the most common cancer. Between 2016 and 18, there were about 48,000 new cases of lung cancer, a substantial number of deaths. The survival is still not fantastic, and a lot of the cases are preventable and caused by external toxins such as smoking. The sort of the types of lung cancer, there are two types, the non-small cell and the small cell. The non-small cell lung cancer essentially is divided into three different groups: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Whereas small cell, we'll see on the further slide, is slightly more complicated. So non-small cell lung cancer is what is operated on most commonly. And it's divided into groups of adenocarcinoma, squamous cell carcinoma, and large cell lung carcinoma. Now, adenocarcinomas are most common overall nowadays. It includes also non-smoker, and I think as a percentage, we see a lot more younger adults and who are non-smokers and develop adenocarcinomas nevertheless. They're typically quite slow growing and don't metastasize too early, whereas large cell carcinomas are sort of the least common, and they can be quite aggressive, fast growing, and metastasize early. Squamous cell carcinomas are most common in smokers and often cause a lot of inflammation around the tumors and are sometimes a little bit more tricky to sort out. Now, I said about the small cell cancer, this is a bit of a tricky spectrum. So there's a whole group of neuroendocrine tumors, and essentially on the very sort of benign end on the left with very little mitosis, meaning very slow tumor growth, is your typical carcinoid. And then going one sort of step further is your atypical carcinoid, which has slightly more a higher mitotic rate, then followed by your large cell neuroendocrine carcinoma, and then the small cell lung cancer is basically the most sort of aggressive of all of them. So this is nowadays thought to be a bit of a sort of spectrum rather than completely distinct entities. And so after all of this, we're just going to be jumping into a case. So this is a 63-year-old male, and he presents to his GP with a persistent cough and a shortness of breath. Now, he had a recent COVID infection in April, and he thinks the cough was because of COVID, but it's going on for a bit longer, so he sees his GP. Now, the GP takes a history and examines, and he finds out that he suffers also from hypertension and has been smoking in the past, has some COPD for which he's on inhalers, but his appetite isn't great, and he's lost a bit of weight. He works as a plumber and possibly has been exposed to some asbestos, but there isn't that clear of a history. And nothing particularly can be found in examination. So what would be your next step if you were that GP? If you have any guesses, feel free to type them into the chat box.
So Karina is saying...
I didn't hear the question. Can you repeat it, please?
So this is a 63-year-old male with shortness of breath, some unintentional weight loss. So the history is on the screen. What would you do if you were this GP seeing this patient?
So Ms Brunswicker, we've got a few answers. So Karina is saying outpatient chest x-ray. We've got Anoop who's suggesting a 2-week wait referral to lung cancer screening for lung cancer screening. Joshua saying CT, and then much of the same from everyone else.
Yeah, okay, lovely. So as a first step, so I guess this is a lung cancer talk, so probably wouldn't come, hence the suggestion of lung cancer screening. But yeah, if you see this patient in clinic, I mean, he's just had COVID, it probably wouldn't be too surprising. He's got COPD, he's been smoking, a bit of ongoing cough after COVID, probably wouldn't be the most sort of unusual thing. So probably referring him to lung cancer screening at this point, well, screening is also kind of, so referring him through the 2-week wait would be kind of probably not accepted as a referral. So they would insist that some sort of imaging to be done. Starting with a CT would be very costly. If we were to investigate every persistent cough with a CT straight away, that would cost the health service a lot. So from the GP pathways, it would basically qualify for a chest x-ray in the first instance. And so this man had a chest x-ray. And what is sort of the most obvious thing that you can see on this?
So we've got a comment saying mass in left hilum.
Yeah, so there's a mass in the left lung. We can't quite say where exactly. It's sort of in the midfield, but that could be either upper or lower lobe, so we don't know. But there is a mass, and now you're right. This is now triggering the 2-week wait and an urgent referral because this clearly doesn't look normal. So this patient needs further investigation, and I'm sure you all know which investigation this patient will be having next.
CT chest.
Yeah, absolutely. And what you want is a CT chest with contrast, and ideally actually a CT chest and of the upper abdomen, because once the lung cancer suspicion is in the arena, you normally try and scan the upper abdomen with it, just to rule out any changes in liver, adrenals, etc., sort of early metastasis. So usually what you request is a CT chest and upper abdo with contrast. It doesn't need a high resolution CT. Some people think it needs a high resolution. It doesn't, because here we're not really concerned about a disorder of the parenchyma, which is what your high resolution CT is for. But this is a big must that will be visible on the normal CT. But what's important is to have contrast. Super. So someone said about red flags, and that's also really important. So GPs are usually following quite strict referral criteria, and these red flags are usually what they will elicit when they take a history. So a cough over 3 weeks is one of those. Other symptoms of cancer, lung cancer, can be recurrent chest infection, hemoptysis, of course, if the cancer is eroding into any major vessels, pleuritic chest pain. If it's a cancer, it's involving the pleura and causing pleuritis, or if the cancer is obstructing a part of the lung and that causes sort of a localized infection and infection of the pleura. Persistent dyspnea, of course, if anything is collapsed due to airway involvement. Persistent fatigue, the loss of appetite and weight loss, as with many cancer diagnoses. A hoarse voice. Anyone know why people would get a hoarse voice?
So we have comments saying recurrent laryngeal involvement.
Yeah, absolutely. So either because your recurrent laryngeal, of course, is very close to where the station 5 and 6 lymph nodes are. So say if you've got a malignant involvement of these lymph nodes and they encase the nerve or similar, then you can have with a hoarse voice. And shoulder pain, very similar. If there's involvement of the chest wall, and finger clubbing, again, is one of these generic cancer red flags. But in particular with lung cancer, you get the hypertrophic pulmonary osteoarthropathy, which is like a really bizarre swelling of the final finger joints. And that resolves usually pretty spectacularly quickly after surgery or after the cancer is it's treated in a cytoreductive way, really. All right, so moving on to the CT again. So this patient then goes on to have a CT. And as you can see here is an axial image of the CT. And again, it's no surprise, he's got this mass, which appears to be in the left lower lobe. And now we are really into the lung cancer referral, because this is not a small nodule anymore that needs some sort of surveillance or some risk calculating. This is now a proper mass, and we are concerned this could be cancer. However, there are lots of things that can mimic cancer. Do you know any of those?
Well, I think that bronchiectasis can lead to clapping.
Yeah, absolutely. Yeah, there are other diseases that can lead to similar symptoms. So the red flags are always very quite non-specific. I mean, with the radiological appearance, sometimes you can get sort of cavitating lesions from tuberculosis or aspergillomas. Stuff like that can sometimes look like cancer, and then it turns out to be not cancer. So sometimes you can get other things that can mimic the radiological appearance. So you can't obviously diagnose a lung cancer just from the radiology unless it's in certain circumstances. So the thing now that we need to do for this patient is we need to stage this cancer. And staging essentially is important because it is helping us to predict how this patient might respond to certain treatments. And in order to stage, you might have seen this in MDTs, is that we stage tumors by T, by the tumor size, by N, by the lymph nodal involvement, and by M, by distant metastasis. And this is called clinical staging because we're obviously we're not there. We don't have this tumor in our hands. We can't slice it and look under it on the microscope. But we do clinical staging on the basis of radiological and other findings. And once we've gone through that TNM staging, then we can put it into these stage categories, and that helps us to predict survival. And so in order to stage, there are quite a few investigations necessary. So we've kind of done a CT. So that gives us an idea about the T. So we kind of know roughly about the size now. So we can stage it in terms of size. Whether it involves, I mean, this one is unlikely to involve chest wall, or at least not significantly so, perhaps it could be invading the pleura, but this is something you really can't see very well in the CT. So that is always a bit of an unknown. So that's why we call it clinical staging, because it is not the final staging. Then lymph nodes we can only very inaccurately stage from the CT. The CT criteria are 1 centimeter. Anything over 10 millimeters is suspicious. But then the problem is that if, say, a tumor causes local infection, or patients have CPD and have regular exacerbations, they might have also reactive lymph nodes, and they can be bigger. So from the CT, you can't quite tell. So you need a lot more investigations to stage this tumor accurately. And the next thing most patients go through is the CT PET. And CT PET is basically an overlay of PET images, which is the one that you see in the left-hand top corner, where you give the patient a radioactive tracer, and that's basically then gathered as a cross-sectional imaging. But just by that, it's very difficult to localize the tumor, because the other tissues, of course, don't show up so well because they don't take up so much tracer. So what you do is you do a CT at the same time, which is the image on the top right. And then you overlay those two pictures, and you get this picture on the bottom left, which is your CT PET fused axial image. And that helps you to localize the tumor a little bit more accurately, so you can plan your resection. It also helps us to see metastases, because if they're anything over a centimeter, they should usually show up. So if someone's got a weird lesion in their liver or in their brain, then that alerts us that something else might be going on. But it also picks up lots of incidental other stuff like diverticulosis and things like that. It's not the greatest in terms of sensitivity and specificity, but once it highlights a certain problematic node, then we can act on that and investigate it further. And further investigations, for example, can be EBUS, which is a type of bronchoscopy with an ultrasound probe attached inside the bronchoscope. And then the bronchoscopist can look at certain lymph node areas and can sample them if needed. The sensitivity and specificity is better, but it cannot reach all the nodes. It can only reach a few of them. And it's also not that easily tolerated by the patient. And then an investigation we use fairly rarely these days is cervical mediastinoscopy. Again, it can't reach all nodes, but if there is nodal involvement in areas where we think it makes a difference to our management plan, then we've got to investigate them this way in order to find out. And so here, this is the current NICE flowchart. Everything's got a flowchart nowadays, but it shows you essentially how you use these investigations in conjunction to give patients an accurate staging. Because if you don't have accurate staging, we can't offer them the best treatment. And again, these are the mediastinal lymph nodes that we are investigating, and you can see they're all numbered and marked, and they have all their distinct areas, which I'm sure at this stage you don't need to know by heart at all. But it just shows that certain lymph nodes we can reach with certain techniques, and depending on where the suspicious lymph node sits, we need to choose the appropriate technique to sample it. And then we might have staged something, but what have we actually staged? Because up to this point, we can't really say for 100% that this lump in this person's chest is actually cancer, because we haven't had a sample from it. So one of the other things we need to do other than staging is also to obtain a tissue diagnosis. And again, that can be done in various modalities. It can be done CT guided, sometimes, and it's very peripheral, it can be done ultrasound guided, and sometimes if the tumor, say, is invading the bronchus, and you can just plug a sample on the bronchoscopy. And nowadays, there's also CT guided sort of navigational bronchoscopy that can help with smaller nodules that are difficult to reach. So various methods. Again, the success rate is not 100%. So if you've got a negative sample, then you might try again, because you cannot be absolutely sure that a negative sample means it's benign. And one other thing that we send our patients to when they're in the higher stages is brain imaging, because obviously the brain is one of the sites of lung cancer metastases. And currently, only the higher stages, just stage 3, go for an MRI. Stage 2 usually has a CT, and that's got to do with some very complex cost calculations, because the data around the sensitivity and specificity of CT versus MRI is actually quite poor. And basically, they try to reduce the monetary burden. So the lower stages that are less likely to metastasize have basically less benefit in terms of quality adjusted life years. So therefore, they go for a CT head. And again, so we've gone through all of this now. So now all these investigations help us. We can measure the tumor size, the EBUS or the CT PET or whatever other investigation we've done to the lymph nodes can help us to confirm the nodal status. And the PET and maybe any other imaging that we've done hopefully has ruled out any distant metastases like the brain MRI, etc. So now we have completed the staging. And according to the staging is now basically what treatment can the patient, well, first we can tell the patient what their sort of, what the survival actually is like, what is their chance of dying from the cancer, versus the risk of the treatment, etc. So it just helps to inform discussions, and that often is really important to cancer patients. And then also the landscape of treatment. So once we've got a stage, we kind of also know which patients will benefit from surgery, but in which patients won't. And generally, the lower stages will benefit tremendously from surgery, whereas the stage 4 disease with extensive disease with distant metastases, they have no survival benefit. So they usually will receive other treatment modalities. Right, but it's not just about, so the first step is essentially we've staged the patient and say we have established now that this patient, for example, is a stage, say 2A cancer. So we say, well, it can be resected. It is something that meets the indication for surgery. But the next question as well, is the patient actually fit to have a lung resection done? And that is the second big part of the investigations. So we will give a very rough performance status and dyspnea scale at the clinic visit just to get a rough idea of how physiologically fit they are, well, how kind of fit on a daily basis they are. But we also do more detailed investigations such as lung functions, which includes spirometry, flow, volume loop, and transfer factors. We sometimes do an echocardiogram depending on their history, a shuttle walk test, and some patients who are particularly high risk or are sort of borderline will go on to have cardiopulmonary exercise testing to evaluate whether they can actually physiologically deal with loss of lung tissue, which is what will be required in order to do, in order to perform surgical treatment. And essentially what we try to assess with these investigations is basically the three big risks of any lung resection, which is what is required to clear the cancer. And that is firstly the cardiac risk, the risk of perioperative death, and the risk of persistent dyspnea, because obviously they'll lose functional lung tissue in the with a tumor. And these risks can be calculated in various ways. And then you can present the patient with the risks and say, right, this is what would happen. And if the patient is acceptable, then you could offer them surgery. But if you think the risk is too high or the patient isn't happy, then you should not offer them a procedure. And what procedure are we talking about? So there are various ways to resect cancers. The most common at the moment would be a lobectomy, where you take the entire lobe that is affected by the cancer. However, if, say, a cancer is at the fissure or invading across the fissure into another lobe, then sometimes other procedures have to be performed, such as taking a ridge of the adjacent lobe or doing a bilobectomy. Some cancers are very central, require pneumonectomy, or some more complex procedures, such as sleeve resections, where you just take one lobe and re-anastomose the other one in order to achieve clearance. However, segmental resections gain more and more importance nowadays after recent studies. And so this is certainly becoming a lot more common. Wedge resections are hardly ever performed other than in exceptional circumstances, because we know that the recurrence rate is really high and the outcomes are not really much better than with the radiotherapy. And what helps a lot for these resections is all the modern devices that we have to our have available to us in theatres. Because as you know, we've just talked about what pipes and lines go into the lung. So in the end, we have to divide we have to divide a vein of sorts. We'll have to divide a bronchus, usually multiple PA branches, and often patients don't have a complete fissure. So you have to complete the fissure. And so on the top right, you can see one of the stapling devices that is used here to complete a fissure, which has 3 rows of very small staples that is used to seal the lung tissue, and a very similar stapler can be used. It's a sort of different staples in it, but same appearance, can be used to staple the bronchus and the vessels. And then you can see on the top left-hand corner, these energy devices. Again, there are various brands available nowadays. They can help in mediastinal dissection of lymph nodes, because they also need to be all sampled as part of the procedure. And then how do we actually get to the lung? How do we actually resect it? Well, approaches are also, depend, of course, of the size of the tumor, the stage, and the lymph nodal involvement. If the tumor is big, then it needs an open thoracotomy, or if there's lymph nodal involvement and you need to do a thorough lymph nodal clearance, then it needs a thoracotomy. And you can see here how to do that. And you can also see what it looks like when you look inside the chest. You get a really good view of the anatomy there. However, minimally invasive surgery is in smaller tumors. Anything under 4-5 centimeter is usually standard nowadays. And again, there's a huge array of approaches. So there's a 3-port technique, and lots of units have adopted the uniportal technique. Now you see on the left where everything happens through 1 port. So there is quite a bit of variability. But on the inside, the actual anatomical resection of the lung remains the same. It's just the axis that is slightly smaller. And of course, robotic surgery is also much more widespread nowadays, and is particularly helpful in some of the trickier and stuck lymph nodes. Now, after the operation, the care of the patients usually happens at level 1 wards. However, some high-risk patients might require level 2 HDU care. For an uncomplicated recovery, the length of stay is anything between 3 to 5 days. And what do we do with the patients? Usually it's just chest drain management. Physiotherapy daily is really important. Sometimes patients require oxygen for a short while. They require analgesia, antibiotic prophylaxis for a couple of doses, and 28 days of low molecular weight heparin. But most of the time, if there are no complications, patients can be out of hospital as soon as 3 days after their operation. And here you can see, again, comparison of wounds. On the left is a thoracotomy. Then there's a uniportal where the drain is in the same incision as was used for the surgeon. On the right is a 3-port butts where the incisions are separate to the chest tube. Complications of surgery, of course, that's something also we have to discuss with the patients, not just the big 3 of mortality and dyspnea and cardiac risk, but there are a lot more common complications. And equally, we need to talk to them about that, because that often affects their home life. Now, for example, prolonged air leak is quite frequent, because obviously patients who smoke and have COPD are also more likely to have lung cancer. Their tissue is poorer, the staples don't sit quite so well, and sometimes a bit of air leaks. The numbers are quite variable depending on where you look. But I'm sure it's anything between 10 to 20, 30% possibly. Some patients go home with a drain and a special bag attached to it to avoid lengthy hospital stays. Pneumonia, of course, or generally respiratory tract infections are common after lung surgery, because pain affects the cough effort and effectiveness of expectoration. Bleeding can occur from the surgical side, of course, and then all the other generic risks of any thoracic surgery. And again, depending on whether the tumor is damage to other surrounding structure, need to be discussed with the patient. And then one of the new developments, so someone mentioned lung cancer screening earlier. So lung cancer screening is not everywhere in England, but in a few regions, where essentially patients of a certain age bracket are invited through their GP to fill in a questionnaire. And if they meet certain risk criteria, they receive a low dose CT and another one in 12 months if the first CT is negative. And that has detected quite a bit of early stage cancer, which helps to deliver potentially curative treatment, because the survival of, say, stage 1A at 5 years is almost 90% after surgery. Whereas if that cancer would have been left to grow until stage 3, the survival is a lot worse. It therefore reduces mortality. And there have been some calculations from up here in Manchester that has been cost effective in our region, where lung cancer rates and smoking rates are relatively high. Right, so I'm sure everyone is desperate for a drink now, but I'm happy to take any questions because I know it's a lot to cover in